Thank you, Helen and Debbie. Thank you so much to Medstrom for inviting me to speak today. Welcome to everybody who's joined us as well. So let's get on to our presentation. There we go. So this is around an article that I wrote for the Nursing Times about the impact of the COVID-19 pandemic on chronic wound care and its practices. So what do we know and where are we? You know, we keep hearing about the burden of wound care, which actually was completed on data from 2017 to 2018. So it's actually before the pandemic. And even then, we'd had a 71% increase in wounds in a 5-year period. And the spend was 8.3 billion. I think the interesting thing for me from this data also is the increase in the number of visits in community and primary care. You know, 54.4 million district nurse visits, and also healthcare assistants. So that shows that, you know, that change in practice within the workforce. And, you know, there's lots of questions and debate around what do we do about that, and you know, where do we provide education to support them. We've got figures there on the ageing population from the Office of National Statistics. That's telling us by 2028 the increase in the over 75s, you know, which is also then going to have a big impact on chronic, you know, comorbidities, which then will have a knock-on effect with wounds also. So the coronavirus pandemic highlighted that there was a low priority given to chronic wounds, and we'll look at that in a little bit more detail. But we know that suboptimal care causes unnecessary suffering. It means more patients are admitted to hospital, there's more patient deaths, and then that spend, the NHS, that 8.3 billion, you know, is just going to rise through the roof. So I'm a tissue viability nurse myself, and what is the role of that, you know, the specialist role in pressure ulcer prevention and management? Well, wound care is mostly nurse-led, we know that, and 2/3 of it is delivered in the community-based areas. So, you know, tissue viability requires specialist skills that the, you know, services and team provide. The role isn't standardised and it is poorly defined. And a specialist resource and support isn't always accessed, it's not resourced very well. And we know from that burden of wound study that there was a 2% decrease in tissue viability access visits. So the TVN role historically has always been around advice and support. I know from speaking to tissue viability nurses and in my honorary role in the area of York that it has become much more hands-on and clinical, not just an advisory and support service. But education and training are really at the heart of what we do, and that's you know, educating the rest of the health workforce, but also within social care too. So it's vital to focus on, you know, prevention within wound care, and especially around pressure ulcers. You know, we are not addressing service, so education for me, you know, is the main part of what I do these days. But also the role of the specialist nurse is to advise our trusts and CCGs on things like the equipment selection, because everything we do is based in evidence, you know, is evidence-based care. It has to be. And whether we are prescribing a dressing or, you know, a mattress, a cushion, a heel offloader, you know, these are prescribable objects. So we need to have that quality from our suppliers. We need their support as well in education. And we need to make sure that we've, you know, our goals and aims made with our patients, families and carers are towards, you know, comfort, dignity and safety. So it needs to be at the, you know, really at the heart of our care planning. So we know that, you know, this has been impacted because of the pandemic. So what were those impacts? Well, the first wave with the pandemic, the plug was pulled on a lot of prevention work. The plug was pulled on education that was being delivered in our trusts. You know, and some patients struggled to just get access to wound care, and some services struggled to provide even an essential, you know, wound care service. So there were reports that patients were unable to access services. We know ourselves, trying to get into a GP appointment was very, very difficult. And, there were lots of services that were being redeployed, especially our specialist teams and tissue viability. Patients were being, kind of left without essential equipments of dressings and equipment at times, or there were long delays in this. I know from doing an audit myself in my last trust in North Lincolnshire, and the audit I did was this year, but was looking at the journey through the pandemic. And this was patients with leg ulcers, but the outcome will be the same across the board. And patients were, they were getting non-face-to-face visits. They were being prescribed antibiotics after antibiotics, given dressings, and by the time the specialist clinics could reopen and patients got seen, we had some quite severe wounds there. And anecdotally, we know that is across other wound types as well. So, experts in the field have been saying, chronic wounds have just really dropped off the priority list. It's never been up there as it should, as other chronic diseases are anyway, but, it did worsen through the pandemic. And, those other associated risks with COVID, we had a big cohort of people who were in a vulnerable groups who were being, who were impacted by COVID, being admitted to hospital, patients in ICU, people were being discharged back into nursing and residential homes to be cared for there to free up hospital beds and things. So, and even, in social care as well, we keep hearing about it in the media, the impacts to staff in there. So there was less focus on those earlier signs of risk assessment, putting those preventative interventions into place. And I know from leading pressure ulcer prevention teams in 2 different trusts, the focus we put towards education into care homes had a big impact, but then they were being redeployed into other areas to work in the past 18 months. The education stopped, the staffing issues, and we did see an increase in pressure ulcer reporting. We've also seen new skin manifestations through COVID as well. So that's something we need to be looking at and learning from. Increased dependency of those ill patients, like I said, and proning was a thing that was happening a lot in those, high dependency units, and a desaturation of oxygen. And so we were seeing different things like, deep tissue injuries on a different scale and new areas than what we'd seen before. And of course, the device-related pressure ulcers, we were using a lot more tubing, masks, and all these different things. So we were seeing and reporting on a lot more device pressure ulcers. So examples of the skin changes that we have seen, we've got the COVID toe. I don't know if anybody's heard of that. That was a new thing that seemed to spring up. And like I said, deep tissue injuries, especially around, the kind of that buttock area, things that you would often see and relate to in end of life we're seeing with COVID patients. There's the oxygen tubing and, different masks that we had, and also moisture associated skin damage. We did an audit in North Lincolnshire and we found we'd got an increase because as part of NHSI guidance now that we are supposed to be reporting moisture associated skin damage. So the incontinence associated damage, like on the photograph here, we were seeing a lot of, and we were, attributing that again to, that the issues we had within, just social care support and people, just trying to look after themselves, look after their families at home and in lockdown. That's what we were advised to do, is to stay indoors and to stay away from people. We've got winter pressures coming up now. COVID certainly hasn't gone away. It hasn't gone anywhere, has it? And so we always get additional things within winter. So are we going to see a rise, increase further again with our pressure ulcer development? we need to, be carefully monitoring and watching the outcomes. We've learned from the past 18 months. So, let's be ready, and we need to be focusing on preventative care. So what were the impacts to the healthcare professionals as well? Well, many, and those of you in the audience who are working in the profession will relate to this. There were staff shortages, and still are, in all service areas. Many were redeployed. Some services, clinics, were temporarily closed. There was the education was stopped, so people not getting education on pressure ulcer prevention, and then that in turn reduces competence in the workforce. That increase in reporting we've certainly seen, and then there were PPE and skin issues for the staff themselves, on the around the ears and the nose, and people having to wear for hours and hours on end, and so they were reportable pressure ulcer incidents in themselves. Increased stress and anxiety, stress and compassion fatigue, even in normal times, is a challenge to prioritize one's own emotions, psychologically and physical well-being. So that cost of caring, that prolonged intense contact with suffering patients, it can be absolutely overwhelming, and it really tests resilience. And it can cause traumatic stress, burnout, you get an exhausted workforce, and then people leave the profession. So that recruitment and retention, sadly, is kind of falls by the wayside. The impacts to patients, carers and families, obviously we have all seen and witnessed this, and patients were often discharged home earlier from their hospital because they needed to free up hospital space, because the hospitals were just creaking at the knees. So patients, I know in the community, we saw patients coming into almost turning care homes into hospital wards, very sick, very ill, very frail patients, and sometimes in a palliative capacity as well. So it increased all the wound types. We kind of, we expected this. And those anecdotal reports we keep hearing more and more of really severe chronic pressure ulcers and other wounds. Some of the chronic pressure ulcers that, we know we still see category 4 pressure ulcers, but some, reports are saying, gosh, we haven't seen things like this for the past sort of 10, 20 years. Also, there's a fear of accessing support from healthcare professionals. Lockdown, people are afraid, were afraid to go out to access the services or even let people in through the door. We've got vulnerable groups of patients in our care, and they had to protect themselves, and we wanted to protect them. There was increased physical impacts on chronic wounds, that pain, malodor, exudate, reduced mobility, all those things that, it can affect a person's life. And the psychological impacts living with a chronic wound, you can get anxiety, depression, social isolation, and that fear and just helplessness. So quality of life, we have to measure, because it does impact and affects all aspects of a person's well-being. And also lack of education towards patients and carers. We need to ensure we really firm this up, and that receiving and delivering of suboptimal treatment interventions with the equipment and dressings, had definitely had a knock-on impact. So sadly, these are the types of pressure ulcers, the real big, horrible, chronic, category 3 and 4 pressure ulcers, and that a burden of wound care told us it can take between 9 and 50 months for pressure ulcers to heal. So positive elements to take forward, though, because there's always positive things to take from when we've had bad situations. So you can see their advancement on the patient self-care agenda, which is part of the NHS long-term plan of health coaching, involving families in the care pathway development, greater focus on digital solution, national wound care strategy, doing a lot of work around this, highlighting the need for specialist services in wound care more than ever, and collaborative working, all of us together across health and social care. So please take away some learning points and reflection from this, that caring for people with chronic wounds needs to be prioritised. The barriers to supported self-care and telemedicine have been lifted, but we still need to do a lot of work on this, and it won't suit all patients. Self-care certainly doesn't mean support and good, that support and good shared care systems are no longer needed. Online teaching that we're doing so much more of, is a different skill. So we need to make sure staff have appropriate training for this. And we're looking also on that holistic assessment of teaching patients around diet management, exercise, smoking cessation, and all those things which impact on wounds. So how can we make a difference? Well, I just want to say that everything we do must be measured, because data speaks volumes. So, gather all your data for your healing wounds, on non-healing wounds, infection rates, measure your outcomes effectively, put smart interventions, smart principles into place, and your quality of life tools. And then you can take these to your senior leaders, and we can then together tackle this burden of wound care. Thank you very much.